The surgical management is very important as a urologist, as a treating surgeon. Of course, medical management, we refer the patient to our nearest center, the dot center, and they take care of it. Surgical management is something which we have to involve ourselves day in, day out. Okay, next slide, please. Next. You take all the animation out. Okay, no, the previous slide. Yes. The indications for surgical intervention will be if there is an obstruction, either at the pelvic junction, infundibular level, or the ureteric level, you have to intervene in the form of double stent or in the form of a percutaneous nephrostomy. If the patient has got calcifications, that calcified that may be a focus of infection, that may be a focus of dormant bacilli that has to be removed. If there is a cavity that has to be drained, if there is an abscess that has to be drained, or the bladder is contracted, the contracted bladder has to be opened out a bit. Okay, so these are all the indications for the surgery in patients with, next slide, in patients with GUTB. I had mentioned that if there is a hydronephrosis, you put a stent across or do a PCN abscess, you drain the PCA abscess either in the form of a stent or in the form of a pigtail. It can be either a PCD or it can be a PCN, whatever it is, depending on where the abscess is located. And then you can plan a definitive treatment for the affected part of the kidney. If there is an abscess, you can drain the abscess, or if there is a calcification, you can excise the calcification, you can do a partial nephrectomy, or if the infundibulum is narrow, you can do an infundibulotomy, you can do ureterocalycostomy, or you can do a cavernotomy. You can do abdominal. If the kidney is totally non-functional, like a putty kidney that I had shown earlier, we can plan for a, next slide, nephrectomy also. If the patient has got calcifications, if the patient has got calcification, as I mentioned earlier, we think that the calcification is a healed lesion. Problem in that is that this calcification may harbor viable bacilli, which can actually get reactivated at the time of the next immune compromised status. When there is a compromise to the immunity, which can happen on a later date, these dormant bacilli can get reactivated. That's the reason why, if there is a calcification, you cannot take it for granted that it's a fully healed lesion. You may have to completely excise the calcification in the form of either a partial nephrectomy or in the form of a total nephrectomy. Next slide, please. Because a calcified one will be devoid of vascularity, whatever antituberculous treatment that you give will not reach up to the calcified area where there is a dormant bacilli located or hidden. Next slide. All this not ready. Next. Yes. This is one example of one with the previous slide. If you can go, you can see a calcification there. And the calcification has been excised here. This is one something like a partial nephrectomy, or you can say wide local excision, or you can say excision of the calcification, or sometimes what we call as an enucleation. No? If you can get a nice plane all around, you can just enucleate that. Next slide. If there's a luminal obstruction, either to the ureter or to the fallopian tube, I said steroids are indicated. That is one absolute indication for starting the patient with steroids, especially when you're putting them on ADT. Also, you can put the patient on a double stent in the form of an internal diversion so that the healing with the fibrosis will actually take place over the stent, with the stent in place. You can do a double stenting retrograde, or you can also do an antegrade puncture and do a balloon dilatation through the percutaneous nephrostomy tract. Next slide, please. Or if it's a distal ureteric stricture, you can do ureterostomy, ureteric reimplantation, upper ureteric strictures, piloureterostomy, ureterocalicostomies. Or if you think that the bladder will need a hitch, you can do a psoas hitch of the bladder, or you can take a flap, body flap, entire ureter is involved, you can do an ileal ureter substitution or auto transplantation. The same kidney can actually be brought down if there is an extensive ureter involvement where you feel that the ileum is not suitable enough for you to do an ileal ureter interposition. You can always go for auto transplantation also. Disconnect the kidney from top and bring it down and anastomose. That's how we do a normal transplantation. Okay, next slide. The indications for nephrectomy. Again, when will you do a nephrectomy in a patient with a GUTB? If the kidney is non-functioning, if you feel that the kidney is not functioning with or without calcification, there may be calcification, there may not be calcification. If you feel that the kidney is not functioning, it is better to remove the kidney, because a non-functioning kidney, which is of no use to the patient, if it is going to harbor dormant bacilli, and that will get released into circulation, in times of immunocompromised status. What is the point in having that kidney with us? Better to knock it off, get it removed. Okay, so non-functioning kidney with or without calcification. An extensive kidney disease involving the whole kidney together with hypertension which needs multiple drugs, or with the PUJ obstruction also where the whole kidney is affected inward, better to knock it off. Or if you feel that there is a coexistent renal cell carcinoma, the whole kidney has to be. There's no question of doing a partial removal or enucleation, whatever. Next slide, please. Indications for partial nephrectomy if it is a polar lesion, if the calcifications are there in one pole, and if the patient has failed to respond after 6 weeks of intensive therapy, and if the calcification, if it is slowly increasing in size, then it is always better to go for removal of the calcification in the form of either partial nephrectomy or in the form of an enucleation or a wide local excision. Whatever it is, you try to preserve the rest of the kidney, remove only the calcific focus. Next slide, please. If it's a cavity, I had mentioned earlier to drain the cavity either with a pigtail, or if you can put a nephrostomy tube into that cavity, drain that cavity as an internal diversion. Whatever you feel is appropriate, you can do that. Next slide. Next. That is one abscess which we have drained now. All surgical, nothing much in that. Okay, next slide. Yes. Inferior ureterocalicostomy. Lot of time we find that the parenchyma is getting a little thinned out, especially the lower calyx. Lower, next slide. The lower calyx will be so hugely dilated, and there will be kinking up of the pelviureteric junction. There may be a Kerr kink, or there may be a hiked up pelvis, in which case doing a proper PUJ pyeloplasty may be a little difficult or challenging. In which case, if the parenchyma, the lower calyx is thinned out, we can always plan for, next slide. In such a case, we can plan for a ureterocalicostomy. Okay, next, it's not properly seen here. The ureter is not, there's another one which, okay. Next slide. Next slide. This is an example of ureterocalicostomy being done where we have, this is a post-op X-ray where ureterocalicostomy directly drains from the lower calyx. Okay, the pelvis is cicatrized there. The pelvis is obstructed. There is no place for PUJ pyeloplasty to be done. So in which case we can directly put the ureter into the lower calyx. Next slide. Next slide. There are a few questions which are raised, which we will discuss at the end of the surgical management. RGP is one of the integral part of urological armamentarium. CM, under CM guidance, we'll have to directly inject a contrast into the ureter and make sure that the quality of ureter that we are dealing with is adequate, not adequate, stricture if it is there, what is the level of stricture, what is the density of stricture, and what is the extent or length of stricture. All that information you'll be able to get if you do an RGP. Density you'll not be able to make, but to a certain extent, depending on the degree of stricture, you'll be able to say whether it is grossly strictured, not much stricture. That information you'll get from your RGP. Next slide. And that will also help you to collect sample from the kidney, okay, for urine, for AFB, and for PCR. The surgical management options for tubercle strictures, all these depending on the length of stricture, depending on the location of stricture, depending on the density of stricture. We'll plan ureterostomy, ureteropylostomy, calico. All this has been discussed earlier. You can also do a transureterostomy if in case there is an extensive distal ureteric stricture and the bladder is also not comfortable for you to go for a hitch or for body flap, in which case you can transpose one ureter to the other side and put the ureter into the other ipsilateral ureter. So the transureterostomy can be a viable option in such individuals. Next slide. Then endoscopic management is possible these days with the high-end gadgets available these days. We can, with the flexible ureteroscope also available, even if the posterior middle calyx or if the lower calyx infundibulum is narrow, we can directly go inside and we can take a flexible ureteroscope, put laser on the infundibulum, open the infundibulum, and then put a guide wire into that, and then put thread one stent through that and drain the system so that no, it is not necessary these days most of the times to go in for a calicography, calicoplasty, cavernography, all that has become obsolete these days. All that has almost become obsolete these days with the availability of flexible ureteroscope and a laser which is available. Okay, so it's all become obsolete now. We can also take the fans access sheath, directly into the, if there are some calcific deposits, we can take the access sheath also directly into the calyx, open the calyx with, open the infundibulum with laser and introduce the access sheath into that particular calyx and then break all the calcification that, and then you can put a stent across, drain all the pus in the calyx and put a stent across so that you don't necessarily have to do a PCN in many of such settings. Okay, the next slide, please. All we talked about retrograde and antegrade, stricture balloon. The next slide. Stricture balloon dilatations can be done for short segment strictures. Then ureterotomy, like how we do a urethrotomy, OIU we do for urethra, same way you can do for, and you can use laser for that. You can do a cold knife available for that. You can use like how we have the accused endopilotomy for PUJ strictures. No? Same way you can do for lower urethral strictures also. You can use the cold knife or laser these days. Okay. Only thing that you should remember is that if you are doing it at the level of iliac vessel cross, make sure that your incision is not directed on towards the iliac vessels. So you have to stay a little away from the line of course of iliac vessels. Okay, the place where it actually crosses the ureter. Next slide, please. Long segment strictures I had mentioned earlier, it can go for ileal ureter replacement. Next slide. All these are only for just for completion's sake. I'm sure all this has been discussed in patches here and there, here and there, here and there. You can do a body flap. This is a body flap which is in progress. Body flap can be done. You can tubularize the flap that is taken and connect it to the ureter. Next slide, please, and complete the anastomosis. These are all very useful techniques which you should keep in mind, especially when you're dealing with little advanced ureter. Contracted bladder. Yes. Next slide, please. So bladder with a capacity of 100 ml. That's a candidate for augmentation actually, and good water. Next slide. This is a classical example of a small capacity bladder. You can see that the capacity is not getting distended. There is a reflex also because of the high pressure mounting inside the bladder because of poor distensibility. The back pressure effects are getting, the pressure is getting transmitted through the ureters to the kidney. The kidney over a period of time will become defunct. It's very important for you to make sure that the functional capacity of the bladder is enhanced in the form of augmentation. Number two, next slide, please. The augmentation can be in the form of sigmoid cystoplasty. You can use ileal segment, you can use a cecum or ileocecum, whatever, orthotopic. Read about all these. I'm just giving a broader overview of what all can be done in a patient with a contractile bladder. Okay. Next slide, please. Next. All these are the augmentation being done. We have here. Next slide. Next. That's all. Any further slides? Non-redeemable bladders. Okay. All this not required for you now. Okay. Next. Then indications for augmentation. Sometimes when augmentation cystoplasty is one which we all normally do, routinely we do. The actual indications for that, for augmentation cystoplasty, you should be able to list it. Which are the ones who actually need augmentation? Which are the ones who can be treated with medical management? Who are the ones which can be treated with anticholinergic? All that you should be able to identify. Any further slides in this? Next. Next, we have discussed. Next. Now, there are a few questions from the audience. Can we take those questions now?
Sir, they've asked if a patient has allergy to ATT, how to identify which drug is causing and who decides the change in drug if it has to be done, sir?
See, there is a very strict guidelines available. There are patients who do not respond well to rifampicin, the red man syndrome, the vancomycin,
Yes,
the
sir.
hepatotoxicity. All these are and nephrotoxicity, hepatotoxicity. All these are very proven side effects are complicated, not necessarily an allergic reaction, but some sort of a toxicity to the drug, side effect of that particular drug. In which case, you have to report it is all actually being. If you see a patient who is showing a response or a reaction to the particular drug, a response and a reaction both have to be referred back to the district tuberculosis medical officer who has actually prescribed drugs because they have to be notified to the government of India also. All these are actually mediated through government of India. And these are all small players who are working for government of India, the Anganwadi worker. the district headquarters medical officer. What do we call the DHMO? What district headquarters DHMO or DFMO somebody? And we have to report to these people, and they will take care of the rest of it. Because that is the way the system should function. It should not be that you individually treat the patient. Oh, he's not showing response to rifampicin. Oh, okay, I will change it to cycloserine. Okay, he's not responding to that. I will put the patient on Dilaminate. That is not the way it should be done. You have to report to the nearest district tuberculosis center, and they will take care of the rest of it. They will notify it to the government of India, and they will find a suitable alternative for that. How to any role of prophylactic DJ stenting? If you feel that the ureter is involved, before starting the patient on ATT, it is always prudent to do the double jet stenting in these individuals. The only problem with the double jet stenting is that it's again a double-edged sword. If the patient also has got extensive storage symptoms in the form of through an inflamed bladder, putting the stent will further aggravate. If you don't put the stent, start the patient ATT, and the fibrosis, if the patient comes back to you on a later date, is non-functioning status, again will be sued in the court of law for not putting a stent across. So that decision has to be wisely taken by you. It should be a shared decision making, and you should document that in your OP file or in your IP file. The stenting is required, not required, whatever be the reason. You'll have to discuss with the patient's attendant also and take a final call. Most of the times, what will happen in Indian scenario is that the patient will say, "No, doctor, I am confused. You take a decision in the fullest interest of men. You take a decision on what has to be done for me, what you feel is appropriate for me, you do." In which case, if the patient has got mild hydroureteronephrosis also, that will be an indication for putting the patient on medicine before you initiate therapy. Because if you put the patient in ADT and then follow them up with, after 2 months or intensive phase, by the time the kidney becomes non-functional, extremely difficult for us. There is another school of thought which will say that start the patient on ATT, then 2 weeks later you do a single shot IVU to see if there is a progression or worsening of hydronephrosis. If you believe in that, if you believe in the if you believe in the concept of doing an IVU, maybe you can do it that way. Maybe 2 weeks of anti-tuberculosis you can give maximum before you decide on whether this patient really needs a stenting or not a stenting. But by and large, what you should remember is that at your level, if you're starting the patient on ATT, where there is a luminal involvement, safer to start the patient and put the patient on double the stent before you initiate ATT. This is in huge contrast to patients with pulmonary tuberculosis. Please remember, a patient with the pulmonary tuberculosis, before you initiate treatment, before you do so offer surgical treatment, you must put the patient on ADT. Make sure that you protect yourself. That patient may be having sputum positive. If the sputum is positive, there is no point in taking heroic effort in trying to saving the patient's kidney. You should in fact try and preserve yourself first. You should protect yourself first, preserve your health first before you surgically treat the patient. Okay, that distinction again you have to make. What is the drug regimen for MDR now? MDR, the FDA approved drug is what I had mentioned, bidaculin. That is an MDR approved drug now. The other second line drugs are to be started with. Clofazimine is available, linezolid is available, dilaminate is available. These are three FDA approved drugs which are available. And apart from that, you have amikacin, moxifloxacin, cycloserine. All those other drugs are also available. Only thing is that there should be 3 to 5 drugs which should be given. This drug should be given for a longer period of time. Short course, the DOTS short course is not valid for DOTS plus anymore. If that is the case, then should we scrutinize urinary tract of a patient with patients with GUTB, sir? I don't understand what you say. For urethral cancer, no, the CT that you do will pick up a lesion, no, the bladder or the kidney. So there is no real need for you to separately scrutinize the urinary tract. You are going to, in a patient with GUTB, you are going to either an IVU or a contrast CT or an MRI, plain for that matter. In which case, you'll pick up any lesion if at all it is present. What is the ideal time?
Hello?
Yeah, please tell me.
Sir, sorry to disturb you. That question is an addendum to the previous question, sir. What I have written in the previous is urinary tuberculosis is associated with the development of urothelial CCA, but not with RCCA. I want your opinion, sir, because literature doesn't have any correlation between tuberculosis and RCC, but there is correlation between tuberculosis and the urothelial CA. So
No, no,
what suggests
no, no,
that?
no. No, no. Pathogenesis of RCC is totally different from pathogenesis of urothelial carcinoma. A chronic irritation of the urothelium can produce a dysplastic, can produce metaplastic changes in the urothelium, but RCC pathogenesis is completely different. What I talked about in the indication for nephrectomy is that if there's a coincidental RCC in those individuals, that will be an indication for nephrectomy. That is all I said. That has got
Yes,
nothing
sir.
to do with the overall incidence of RCC on the rise in patients with GTB. You should not take it as in that way.
Yeah,
Okay.
understand that. I understand that in that case, if there is a urothelial CA, in endemic case, in endemic region, do we scrutinize for CA also, sir? That is what my second question.
I think you are making a statement, not a question, Chandramouli. But
No, sir. The
uh,
question I'm asking is, there is a correlation between urinary tuberculosis and urothelial CA. If that
you
is
are
the
asking
case,
or you are telling? You saying that
no,
there
there
is an
are
associate?
no journals. Some of the journals I have referred there is correlation, sir. If that is the case, in endemic region should be scrutinized for CA also in GUTB patient. That's my question.
I am not very sure of the answer because I have not gone through any of the papers which say that there's an increased incidence of association of urothelial carcinoma in patients with urinary tuberculosis. What endemicity you are talking about? Are you talking about the Balkan countries with the GUTB where there is an endemicity we talk about for urothelial carcinomas, or in Indian scenario you are talking about certain parts of the country, certain states of the country which have a stronger association of urothelial carcinoma with urinary tuberculosis? What does the journal talk about? Chandramouli.
Uh, Sorry, sir. Maybe I'm deviating this course. I will message you personally, sir. Thank you, sir.
Okay, because I'm not very sure what exactly you meant by that. But if there is such an association, I'm unaware of it. Maybe you can go through that a little more in detail and put that answer in the search group also, Chandramouli. Or if I find some answer for that, Surya, please note down this question. Okay, and remind
Yes,
me
sir. Yes,
remind
sir.
me tomorrow. Let us
Yes,
go
sir.
through the literature that Chandramouli is talking about and see
Yes,
if we
sir.
can get some answer for that. As
Yes,
of
sir.
now, I'm not aware of any stronger association between malignancy and GTB for that matter. All that I can say is that chronic irritation, inflammation can produce dysplasia, metaplasia that can lead on to. But if there is any endemicity that Chandramouli is talking about, I'm not aware of it. We'll go through that. Okay, later. When should we as
Yes, sir.
reassess the patient once AJT is started? What are the tests we should ask for? Also, when to remove the double chest stent. Double chest stent should remain inside the body as long as the intensive phase of therapy is over. That is 2 months. Normal polyurethane stent that we put in will remain inside the body safely for 3 months. If you put a silicone stent that can remain inside the body for 6 months up to 1 year. If you feel that this particular individual has shown response to the anti-tuberculous therapy that you have given, the minimum waiting period of 6 to 8 weeks is mandatory for you to decide on when to remove the stent. So normally, if you put a stent across, you will not remove the stent within 6 weeks to 2 months of the intensive phase. Normally, after the intensive phase is over, you put the patient on two drugs for 4 months. That is the time when you think about, talk about removing the stent. Okay, so safe period is 6 to 8 weeks. And what are the tests we ask for? You can do one gene expert again. If you want, you can repeat it. If it was earlier possible, you can repeat one more. The problem with gene expert is that again, it will pick up a fragmented DNA which will show positivity. What you should remember is whether the clinical symptoms have improved, whether the radiological abnormalities have come down a bit, whether the hydronephrosis or ureteronephrosis, which was there initially, has come down. All those are the other parameters which you may have to take into consideration. But that does not mean that you can remove the stent based on those parameters. If you feel that the patient's overall symptomatology has improved in 6 weeks to 2 months' time, safely at the end of 2 months, you can remove the stent and then also put the patient on serial follow-up. Do repeated imaging in the form of an ultrasound, not necessary to do a CT every time. Do an ultrasound to see if there is any progression of hydro. If there is a progression of hydro, then you can always consider keeping the stent for an extended period of time or reinserting the stent. That decision you will make on an individual basis. Sir, any role of DTPA in functional doubtful? Yes, of course. There is always a role of DTPA. DTPA, whenever you feel that the function is in doubt, or function is in question, always better to do a DTPA in the initial setting itself, because tomorrow, 2 months later, 3 months later of starting on ATT, the patient should not pursue in the court of law saying that before starting on ATT, I was perfectly normal. Now, after starting an ATT, my kidney is gone. So that liability should not fall on you. So it is always better to have a functional assessment, especially when you are on top. If the contrast CT that you do or the IVU that you do not do excretion of contrast into the collecting system. It's always safer to get the DTP done, to get the baseline functional assessment done. That may not be the representative function because of obstruction, but still at least some baseline data you will have. Induction phase HRST 2 months, maintenance phase 4 months for drug sensitivity. Yes, for drug sensitivity given. For drug resistant, HRST has got no role to play. Somebody has asked how much time take completely resolution of hydronephrosis. The residual hydronephrosis will remain in the body forever, will remain in the kidney forever. The only thing is that the progression of hydronephrosis is what we are talking about as a response to therapy, non-response to therapy. If the patient is not responding to a therapy that we have given, if there is a progression of hydro, that is what we are worried about. Resolution may happen, may not happen. If you had picked it up a little early, then resolution may happen. It is similar to what we do, what we see in patients in whom we do a pyeloplasty. After pyeloplasty, 10 years later, if you do an ultrasound also, they will show a hydronephrosis. Even for that matter, ureteric stone for that matter. If there is a hydroureteronephrosis, you are doing a URS for that individual, removing the stone, 2-3 years later also there will be some mild hydro which will be there. So it is extremely difficult for us to say the exact time that it will take for a complete resolution. The complete resolution may happen, may not happen. What you should be more worried about is a progression of hydro. That will happen if the patient is not responding to ATT. What is the ideal time for stenting in GUTB? I think we discussed that. Okay. If there are no further questions, we'll go to the last topic of the day.